Okay, a few basics. Like if you ask any American, because it's becoming, the notion of donation of the organs in a good and a bad way was popularized in TV shows and other things. If you ask a random person, would they donate a kidney to somebody, 1 in 4 actually would do that. Now, this does not match with the actual numbers where people actually follow up on this and donate. But the readiness is there, so people know that. The most common thing when I ask folks when they come for the evaluation, the recipients, I ask them, do you have any potential donors? And says, well, I don't know. They never release the information. The friends and family oftentimes don't even know that they're on dialysis. So in general, there are 4 types of 4 ways how to donate the kidney. The first one is the obvious one. When you have a family member or a friend and they are a match, you can arrange for the surgery and go through the transplant. Another one we have mentioned also is the altruistic. This is if somebody on the list gets lucky, and because there is a good individual who would like to donate the kidney to anybody. So this makes it easy. And it helps us also at our center because those altruistic donors can actually spur a chain of events. So we try to see if we have a donor, and Dr. Bingaman started all this program of exchanges, is if you have a donor, can the donor just donate to the first patient on the list, or can we help a number of other patients that have living donors but cannot be transplanted because those donors are not compatible. And we have completed just, a couple weeks ago, another chain like this, 5 transplants started by a donor who just wanted to donate a kidney. So we didn't have 1 transplant, we had 5 transplants. So what happened was the person donated to the first person who had a live donor but not compatible, and then the person, after those 5 transplants, the person who was on the top of the list could get finally the kidney, and everybody is doing very well. Another one, and Dr. Bingaman talked about this, is the pair exchange. Okay, so the idea of the pair exchange is to get a match between the living donor and the recipient. And finally, the incompatible part is sometimes there are so many difficulties based on folks who had a transplant previously, women who were pregnant, that they have so much antibody that it's very difficult to find a true match for those folks. Then we can employ other methods like desensitization procedures and other things, but it's also made much easier if there is a living donor available, because we can look for somebody who is the best possible match and then do the procedure. Because there are centers in the country that would advertise the desensitization as a first step, and those folks have very, very high rejection rates. So when we do this very carefully and we have those tools, then our rejection rates are much, much lower, and successful transplant can be then made. The one thing to always pay attention to is that the donor does not have to be a match. Because a lot of times, this is one of the questions that I ask folks, do you have a donor? And say, oh yeah, but they are not a match. And truly, those people usually come from other centers and say, we're told we can't do anything about this. And this is when Dr. Bingaman and I came to the transplant programs. We saw all those stacks of charts, blue charts, that these were charts of patients that had a donor, but nothing was done with it. So this is how the exchange program started. And a lot of people were transplanting and happy today. Okay, the benefits of the living donation. The obvious one, this is why we all here, is that it decreases the wait time. You're very soon off dialysis. Sometimes even you can avoid dialysis and all the problems associated with it, the tiredness, the nausea, the dietary restrictions, and the whole thing about having to go to the unit or having tons of bags with solutions for peritoneal dialysis at home. The other thing is that, but this is true for any transplant, but especially for living donation, that people on average live twice as long with a kidney transplant than staying on dialysis. The living kidney, the major benefits, all the donors are healthy. We know that they are healthy. We know that they have a very good kidney function in order to donate. So the expected lifespan of those kidneys is twice that of what we call or used to call cadaveric kidneys. The surgery can be scheduled. This is a very important part. A lot of times when you're on the list and are sick and then are called for a deceased donor kidney transplant, people may not be optimized. So they take much higher risk going into surgery of incurring a heart attack or getting a stroke or getting bleeding complications or infections. The deceased donor transplant is more of an emergency situation. Whereas with the live donor transplant, you can tune people up, you can do this at the most convenient time, and it's in fact an elective surgery. So this drops the risk of folks dying during the surgery and also having complications. Not only that, but if you have a living donor, you help other people who are on the list. Because you don't get the deceased donor kidney transplant, somebody else who does not have any friends or family and is all alone in the world can get a kidney transplant. Not only that, but because the living donor kidneys live longer, there is less of a chance of you coming back and crowding the list again. It's about, 20% of the list right now is covered by folks who had a transplant before but failed. Okay, so this is a very important point. And another thing is sort of the benefit for donation. If you were a donor, because we cannot predict the future, we can do the best evaluation as we can on the donor regarding the risks. But if the donor, for whatever reason, smoking cocaine or developing bad disease, anything, loses the kidney, they are put close to the top of the list. So they usually get transplanted, even with our long waiting times, within a few months. Okay, so that's an extra security blanket to anybody who would like to consider living donation. So general things. Now there are little things because we perform a very close evaluation of every donor. This is why we have a separate live donor clinic, so the donor's rights and safety are protected. Okay, so generally the person has to be at least 18 years of age. You know why? This is the age of legal consent. Okay, this is number one. The patient has to be able to understand the risks, what they're going into, and has to be able to legally consent. There are some exceptions to that rule in a pediatric transplantation, but that's not a rule, and that's pretty rare that it ever comes to light. But if you have a donor, they have to be 18 years or older. They have to be obviously medically and psychologically healthy. The common things, because people say, oh, how do I know if they would be a suitable donor? I don't know their health status. So there are a few obvious things that if you talk to people and they say that they have diabetes or they suffer from cancer, they have already a kidney disease, that's a thing, so have, for example, HIV or hepatitis, those people, if somebody says that they have it, they probably won't be a donor, okay? The whole other rest you should leave to us. We evaluate the donors and we make sure that they are absolutely healthy and safe to donate. There are a few things that people ask a lot because with age we all have, like if you're 60 years of age, if you're generally very healthy, never had medical issues, you have about 60% of the chances of developing high blood pressure. Now high blood pressure used to be something that would prevent people from being a good donor. It's not necessarily the case now, and we evaluate those folks on case-by-case basis. And in general, if you're white and you're over 50 and you have a little bit of high blood pressure, easily controlled with medication, you still can donate, okay? There is a higher risk of association with high blood pressure and kidney disease in the Latino population, especially in African Americans, so they usually would not qualify, okay? But the major thing is allow us to decide. The donors don't pay for the evaluation. You never know who is doing whom a favor. And I have to tell you this, about once a year, among our donors, we save some donors' life because, for example, they had a kidney cancer and they never knew about this. Because people say, oh, I don't want to endanger my donor's life. I mean, what would you say then? If you could be a donor and find out that you have a cancer and be treated, those people who, because they wanted to be a donor, their life was saved, because they would not have known that. There is no way. They would have been dead in 5 years. So you always have to think about this. If you think that you impose a risk on somebody else, we are not in charge of our destiny, but we may be doing somebody a favor by letting them help us. Just remember this little tidbit.
What is ESRD?
ESRD is end-stage renal disease. This is when you're already on dialysis. Sorry about this. And there is a few steps that the donors have to go through evaluation. The first time, if you have a donor identified, we're going to check if they are already compatible or not. If they are, then we move very fast with the evaluation, okay? If they are not compatible, then we would ask them to agree to participate in the donor exchange program, and then very quickly, and we check it at least once a week, our incompatible population, if there would be somebody already in our system who would be able to participate in the exchange, so this person can be donated. If that's the case, then we would move very quickly with the further steps of the evaluation. Now, the patients will be asked by the nurse coordinators, do a little review of the health history. If everything is in order, they're not active alcoholics, they don't have already one kidney, any of the obvious things, then they will be tested. So they will test, the very common thing is the 24-hour urine collection. To estimate the kidney function, we have to know that they have, of course, good kidney function in order to donate. Then we do a little infectious disease testing, check labs, other things, and then when everything looks good, we would invite them for an appointment to visit with the nephrologist, with the surgeon, and the rest of the team, okay? Now those kids, because there are a lot of people that have family members in other states, those things can be arranged locally. So people don't have to travel for all those steps. The labs can be done locally. We had people coming from New Jersey, for example. We had a guy who came from Spain. And this evaluation can be done locally. We can contract to a nephrologist locally who can evaluate those folks and tell us, okay, this person looks good. Eventually, they will have to be seen by us because it would be unfair for folks to agree to donate the kidney and not meet the team. And we also have to make sure that the evaluation by somebody else meets our standards. Okay? And then finally, we have selection committee meeting where everybody, the nurses, social workers, dietitian, and the nephrologists and the surgeons meet together and evaluate in great detail the chart, the information that we have on the donor. And if this passes the muster, then the person is cleared and then the surgery can be scheduled. And the final thing is the surgery.
So how long does all of this take?
It can take as short, from my experience, as short as 2 weeks, but they're usually like about 6 weeks.
Okay.
Is that true? Yeah, because there are certain things, and let's say somebody is before dialysis, and every situation is taken also individually, and to see for us what the urgency is. Okay, a lot of times things have to be arranged according to the donor's schedule. Let's say somebody is a teacher, and the summertime would be the convenient time for the donor. We have to consider those things. Okay, but generally things can move very quickly. Okay. Yes, sir.
On recover time, say for example, your example, they're a teacher.
I'm getting to it.
Oh, okay.
I know I'm slow, but we're getting there. So the surgery. The original surgery was an open surgery where they had to remove the kidney. This is not the case nowadays. We performed laparoscopic surgery. It's pretty much standard unless you end up in Las Vegas and you wake up in the morning in the ice water. That may not be laparoscopic surgery. So there's generally the recovery time is much faster. The cosmetic results are very good in general. and folks, it shortens the stay in the hospital and also risk for complications. So this used to be the case, and on the flank, on the right or the left side, you would have this huge incision to expose the kidney and then remove it. Nowadays, the surgeons use like various amounts of those little cuts where they have to put the camera and the instruments. They put gas, the CO2, in the belly to create like a little tent. And then kidney is not a small organ, right? It's about this big. So it's impossible to have only like one little scar like they do for appendectomy or for a gallbladder surgery, because they cannot squeeze the kidney. The kidney has to be protected, okay? So there will be a little bit bigger scar, and depending on the surgeon and your preferences, it can be done here as a bikini cut. Usually it's below the belly button a little, where we have this natural line. A lot of people heal very nicely. The scar is almost invisible after a couple years or so, okay? But we have sometimes young females who want to look as beautiful as ever. Our surgeons can do this bikini cut. Now, this is true for all situations except for the nude beach. You would still be able to see it. Now, the recovery. Sir, pay attention, please. So the recovery is, majority of the patients would come, undergo the surgery. They're a little bit doped up for a few hours. And if they feel well without too much nausea or too much pain, they can leave the next day. So about, I would say, half of our patients nowadays with our carefully pre-selected surgeons will stay overnight, leave the next day, okay? Sometimes people have a little more nausea because it's a little bit different surgery. They have to go through the belly, so the bowel gets irritated. Pain is not so much an issue as it is the distension. People feel bloated and yucky, okay? Once they go number 2, they feel much happier, okay? But it takes some time. If we don't kick anybody out, if they still suffer, because it's easier to control those issues in the hospital, and they don't have to, take care of the kids at home and so on, we would allow them to stay longer, okay? But generally, you can go home after the second day. Now, we recommend to people to plan to take about 2 weeks off. I have had people who return to work in a desk job on the 3rd day after surgery, but there are very few people like this. Usually you are expected to feel uncomfortable and have to use some pain medications for about a week to 2. Now, because of the risk of hernia, we ask people not to do any heavy lifting for about 6 weeks. So if your job entails heavy lifting, obviously you will have to be on the light duty or maybe stay out, okay? But generally, the vast majority of donors can return to work after 2 weeks. We try to get the donors right after surgery out of bed, so to prevent any clotting issues or other things. And they will require some maybe anti-constipation medications and some pain medications, okay? Now, what's the general risk? Now, there is nothing that we do as human beings in the world that would say we are absolutely free from dying, okay? You send your kid to pick up milk at the corner store, they have a chance of dying in an accident, right? No human activity is 0% risk of dying. So the risk of dying from kidney donation is about 3 to 5 in 10,000 surgeries, which is exactly the same as bearing a child, right? What I like about the transplantation, I often liken it to practicing obstetrics, because people come into the hospital, they suffer a little bit, they moan and stuff, and they go home all happy with a new life, right? But things can happen: stillbirth, mother dying during the delivery. There are things that are absolutely unpredictable. So this can happen, but the risk is very low. Living in Texas for a year is about as dangerous as donating a kidney. Sometimes more. Now, there was the major concern is, and this was a big fear of folks, if I donate a kidney, is my lifespan affected? It's actually not true. There were studies done to this, and there was a paper published from the Scandinavian area where they evaluated the donors and compared them to the same group of people who could donate a kidney. They were healthy enough, but didn't. And it turned out that the living donors lived longer. So the title of The paper was living kidney donors live longer. That's not that somehow donating a kidney is good for you, okay? But people get the extra education. A lot of times they change their lifestyle. They know about healthy living. So that's another benefit of having people donate a kidney to you, because they get all this education. I cannot tell you how many people we have that came in, they wanted to donate a kidney, but they were a little overweight. How many of them actually changed their lifestyle, avoided diabetes in the future? There are certain things that you, as a recipient, actually give to your donors as a benefit, aside from the satisfaction that you saved somebody's life. So the life expectancy is unaffected. One of the common things that we see in donors long term, that because kidneys regulate the blood pressure, okay? That if you have reduced kidney mass, meaning you have one healthy kidney instead of two healthy kidneys, then you have a slightly higher risk of developing high blood pressure in the future. As long as it's treated, then there is no added risk to it, okay? There are a lot of donors who come from families. There's a lot of unknown also about potential kidney disease in the families. So people think that there may be a slightly increased chance of getting kidney disease in the future for donors, okay? But it's still, if you take the worst case scenario for living donors, the risk of ending up on dialysis is still lower than an average population, okay? And the quality of life, there were papers who studied the quality of life in kidney donors. So the quality of life seemed to be unaffected, if anything, because of the perception of having done something good for your fellow human being. That's the only power that we have. It's not the money, it's not the amount of food that we have, but can we actually help the next person? It has an incredible and a lot of times underestimated value for our well-being, okay? Not everybody can say that they saved somebody else's life. They can say how much car they have, what house they have, you know, but really that's pretty rare. And this is also something that I would encourage you folks, because there is a lot of situations where parents, I ask the parents, oh, I don't want to put my kids at the risk. Okay? Now it's not for you to decide. You always have to think, if I were somebody's son or daughter and they needed a kidney, how would I feel if they say, oh, I'd rather die, 5 years earlier, but not, your kidney is not good for me. You go use drugs or something. You can't do this. We cannot tell what to do. People, you cannot ask your kids, oh, I suffered with your birth, and now and you gotta give me at least one kidney. The other one maybe for your father or something. You can't do this. You cannot play on somebody's feeling of guilt. You cannot force your children to donate to their siblings, because we had situations like this. But you have, and your children have the right to know that you need a kidney.